Good afternoon, everyone. Thank you very much for coming to this St. Paul's Hospital Grand Rounds. Before we get started, I just want to perform a land acknowledgement. We acknowledge that we're gathered and grateful to live, work, and play on the traditional, ancestral, and unceded territory of the Coast Salish people. That includes the Musqueam people, for which UBC is on, the Squamish, the Stalo, and the Tsleil-Waututh nations. And we ask that those not on these lands to also reflect on the territories that they are currently in. We have many people online today and also people in the room. Thank you all for coming. And it gives my great pleasure to introduce one of our really eminent faculty, Dr. Anthony Gador, who did his medical school and residency and fellowship training here at the University of British Columbia, and he was an outstanding trainee, has only proven to be an even more outstanding faculty member. So we're really pleased to introduce Anthony to give this grand round session. And I think this idea was born out of Dr. Gador's real interest in medical mysteries. And even when he first graduated and started on staff, he was really keen on patients that were very tough, the real head scratchers that people could not figure out what was going on with them. And we know that there are always these kinds of patients. And so he came up with this really fantastic creative idea, which is to create a place for these kinds of patients and have sort of a more panel or holistic type of approach, try to really dig and solve these patient problems. So we're really grateful that he's coming to this grand rounds to talk about the PURCC clinic. Thank you.
Thank you for that introduction, Dr. Khan. Before we go any further, hopefully the video can see, I just want to introduce Michelle Hatanaka, who was instrumental in getting this going. I think it takes a team, and she is the leader at the helm, keeping me on track, keeping the patients cared for. And so I am so indebted, and I'm so thankful that you wanted to go on this journey with us and with me. And again, I just can't thank you enough.
Thanks. That's very interesting.
Lights are up. So yeah, I'm here to present something I'm excited to show you guys, and we've been working very hard on it for the last year or so, called the Providence Undiagnosed and Rare Conditions Clinic. Nadia's already done the land acknowledgement, but I'll do it again. So St. Paul's is on the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And it's just important to note that there's still a lot of work to be done on reconciliation. A big acknowledgement to the Virani Innovation in Medicine platform. Without this funding, I mean, we couldn't really even get the show on the road with funding the nurse and getting the meetings going. And so I'm very appreciative of the opportunity to pilot this idea. And again, just important to have this kind of sponsorship. So in terms of the outline, nothing major. It's really only 4 major points. So the first one would be an introduction to the concept of consultative medicine, which is not anything new, but I think it's newly described. So we'll go over a New England Journal editorial article that I think gives a great outline for this approach and how it can help specifically these kinds of patients. We can go over an overview of models for these diagnostic programs with a focus on the US centers, but there is an international need and focus for those with rare and unexplained diagnoses. The next one would be more local. So our own experience at St. Paul's with the Fellows Clinic, formerly the Chiefs Clinic, but endearingly called the Casson Clinic, which has been, since time immemorial, as well as the kind of legacy into the Providence Undiagnosed and Rare Conditions Clinic. And then a look towards the future on what our goals and objectives would be with this program, if we can continue to move forward. So it's the team, and I just wanted to give a chance, and I couldn't get everybody on there because we've had a few people float in and provide opinions that were really riveting and helpful, but I just feel so honored to have such excellent, these are the best physicians I know, that not everyone's on here, but I'm just so appreciative of their ongoing commitment and interest and their want to help my patients, and I want to help them. And again, we couldn't do it without the team. So I'm so appreciative. So that's, the names are on the side, but yeah, too many to go over because the team and the job is so big. Shout out to Department of Medicine. Thank you guys so much. Kind of unsung heroes. So Mary Tondo, from everything of, early morning IT at 6 in the morning and everything else in between. Thank you. Faisal Aziz for helping us keep on track with how to deliver on this and how to move it forward from an institutional perspective. Mahak, thank you so much for setting us up. And my physician colleagues, Dr. Andy Ignashevsky on the left, I reversed Dr. Palapu and Dr. Chapman, but from Department of Medicine, again, instrumental in getting this idea into something concrete and deliverable. And, with the concept of consultative medicine, I mean, these were tremendous internal medicine mentors. I mean, Dr. Barry Casson needs no introduction, incredible mentor at St. Paul's and elsewhere. Dr. Mike Kenyon, also very instrumental in my clerkship years and beyond, as well as Jake Onrod. And, those discussions with Jake and Barry in the morning were just such formative educational experiences. And I think these internists have really shaped a lot of people's lives, both inside and outside of medicine. So I'm very grateful. And last, but certainly not least, is Dr. Luke Chen, who also probably needs no introduction. He's a hematologist and adjunct professor with UBC, but is out at Dalhousie. He's heading up the Coastal Rare Inflammatory Disease Program. So this represents a coast-to-coast collaboration. He's an international expert on such a variety of interesting and rare disorders, from histiocyte disorder to cytokine storm, IgG4-related disease, hypereosinophilia, and was the Castleman Disease Collaborator of the Year recipient in 2024. So again, thank you so much, Luke. He's a contributor to our multidisciplinary panels and just so helpful in the mentorship of getting this program up and running and how to bring it to the next level. So thank you so much. And Michelle Hatanaka, and unfortunately Joe Richards couldn't be with us, but the clinic wouldn't be the clinic without the nursing support. So that's really the tip of the spear. Given that this is about tough cases, I think we should just start with a case. So case number one, which is honestly, this was the progenitor case for getting an infrastructure going, that this was a very sweet 52-year-old woman who had some lifelong challenges with low IQ, some developmental aspects, craniofacial dysmorphisms, chronic pain, and really, unexplained kind of neurological phenomena that really defied a diagnosis. Unfortunately, she suffered an unexpected postoperative respiratory arrest, and for closure and a diagnostic opinion, is asked to provide a posthumous diagnostic review. And it was really notable for she took it with a lot of grace, but this lifelong diagnostic odyssey that also resulted in an opinion at the Mayo Clinic with no clear answer outside of that. At a certain point, mastocytosis was considered and ruled out. So it was quite a story with twists and turns. Here's another case with painful sclerosing cutaneous eruptions, and the problems list was much longer than this and so hard to go through. But they have familial chylomicronemia that's gene negative, and recurrent pancreatitis felt related to that, and a question if they have localized or systemic sclerosis. It was bad enough that they would get repeated skin and soft tissue infections and line-associated thrombi. They even needed an escharotomy at a certain point. A low but not undetectable alpha-1 antitrypsin. And here's another case with a 59-year-old with recurrent low serum ascites albumin gradient, who had a pancreatic anhylar mass due to diminishing performance and non-diagnostic biopsies. He had elected for more of a palliative approach, but is seen in clinic on follow-up because he has a rebound recovery on palliative dexamethasone. And he's had, I think it was upwards of 6 anatomical pathology specimens and no clear diagnosis for this very abnormal mass. And then the last one is a transfer to our CTU with acute kidney injury, eosinophilia, anasarca, and PTH-independent hypercalcemia. And I mean, we can go on and on and on. Like you get the point that there's no shortage of these cases that, like, who do you call? Is it rheumatology? Is it infectious disease? Is it, immunology? They're really not fitting a specific pattern or pathway that we have. And this kind of goes to the concept of diagnostic odyssey. So I would really describe it as a crisis and a massive unmet need and care gap. So, you know, the system is really designed to have high throughput. I mean, we're at surge level 3 right now. There is an issue with getting patients seen with well-defined illness. But if you don't have something that's well-defined, or you don't have a cohesive label, you end up kind of tumbling through from an appointment to a scan, to another appointment, to another referral, with really no clear understanding where you stand. And there's a lot of anguish associated with that. It's mainly the anguish in unknowing when I speak to a lot of these patients. One of the UDPs in Belgium had, you know, remarked that it was 19 years in their adult cohort that onset of symptoms to diagnosis was close to 2 decades. So that's pretty staggering. And then in the Canadian experience, just on an Ipsos poll, so not in the primary literature, for Canadian Organization of Rare Disease, roughly 4 years with 6 assessments and 3 missed diagnoses. I think it represents a pretty significant system failure. These patients are very costly, and we end up seeing them anyways. They show up time and again, and so it's a cost that we're already incurring. So we might as well harness and somewhat streamline the process for people that are diagnostic orphans, and provide a home and some sort of approach for those that don't have a clear algorithm available to them. So this was an article published in the New England Journal a few years ago called Consultative Medicine, and they describe it as an emerging specialty. But I think it's more of a frame of mind, and it's more of an approach to our thinking that, you know, it's newly described, but I think this is what's kind of key, or the ineffable component of what being an internist is. Like, what is actually going on here? What is the actual problem? So they've defined it with a particular emphasis on generalism that uses observation, you know, the basics, talking to your colleagues, observing the patient, taking your own history, and then reviewing it and integrating it with some of the cutting edge technology that we have available to us, and it's becoming less costly and more available. They described generally 4 types of patients that a consultative medicine approach can help. So the first one that is of interest to us is rare disease, and it makes sense that these are not high frequency conditions. How can they be recognized? So that can help them. And then another one, which I think we actually encounter more often than we'd like to admit, is atypical presentations of more common illnesses. The other 2 that presently the clinic isn't designed for or optimized for, or it's not our mandate, is these kind of new or undefined conditions like long COVID or myalgic encephalomyelitis, or chronic fatigue syndrome. And then this increasing body of aging patients, and a big demographic of complex multi-morbid cases that need a generalist to manage their comorbidities. I think that also needs a significant amount of work, but it would be better addressed with a different technique. In reviewing their literature, so it seems as if there's 2, or the impression is that there's 2 general approaches. So one would be the second opinion approach through the Mayo Clinic, which is based in Rochester, Minnesota. That's been around since the late 1800s and then formalized in 1919. And that was really through word of mouth, through excellent clinical care, excellent surgical outcomes, and excellent recruitment of a massive panel that provides good diagnostic and surgical opinions. So that's a second opinion model. Really, anyone can show up to the Mayo Clinic to get an opinion, or anyone can refer. There's no barrier to accessing the expertise. On the other end is the Undiagnosed Disorders Program that was coordinated through the National Institutes of Health in Bethesda. So that was in the late 2000s, and their results were published in 2018. That expanded out to the UDN, which has affiliate universities and centers from, Baylor, Duke, Harvard affiliated schools in Boston. And that one has a predominantly pathobiology basis of their approaches, that they want to understand these undiagnosed disorders at a biological level and to describe these new diseases, and would really only take the most challenging of cases. So in a public payer system, resource constraints, I think having a harmonized approach between the 2 is probably what would be a best fit for our local community and our local needs at, BC and Vancouver. So just looking over some of the data with the Mayo Clinic, it's a generalist review. They review all of your data that you've submitted to them. They assess you from a general sense and then organize subspecialty assessment and opinion, and then have a wrap-up review to clarify any findings or recommendations. So Van Such and colleagues in 2017 published a review of roughly 300 patients, and their outcomes were generally in 3 categories. So category 1, no change from referring diagnosis or no meaningful change. Category 2 would be a more defined result, and category 3 would be a major pivot in the diagnosis. As you can see, there's a few examples. So just focusing on category 3. So weight loss was better defined as, malignant lymphoma, body aches from bone pain, more better described by acute myelogenous leukemia. So in 286 cases, roughly 21% of those cases were in group 3. Just looking at the costs, I don't know why that's a Japanese yen, but sure. Even a group 1 diagnosis incurs cost, but as you can see, in group 3, to really revise a diagnosis from prior, it's very costly. It's nearly $5,000 in non-inflated dollars from 2017, with a very large standard deviation. So it is costly to de-diagnose or re-diagnose what the condition is. The final diagnosis on post-review, I couldn't access their appendix to figure out what were the specific, they didn't describe them in terms of ICD-9 codes, but MSK, constitutional, and neurological were the final diagnoses, and diagnoses most likely to change were respiratory, mental health, and kind of another kind of vague cluster, and then circulatory. Pivoting over to the UDP clinic. So this is at NIH. Again, the mandate was, the large portion of it was scientific. And a big takeaway about the patients that they saw, it was, neurological symptoms was a primary reason for referral in almost 40% of the cases. So as you can see, 1,500 are referred in terms of an adult, so it's pediatric and adult. So around 900 adults were applied, whereas only 250 some odd were seen in total review. This is a breakdown of presenting problem by system. And as you can see, neurological dominates, with MSK and immunogenic being kind of 2 and 3, but in distant second and third. I think a really interesting thing when I had actually read this when it got published that excited me quite a bit was, the diagnosis was made on clinical review in roughly 11% of cases. So that to me just speaks to what can you harness just by being thoughtful and mindful. You don't need, genetic sequencing and proteomics and advanced laboratory testing. It's with the information that we have, with what anybody else could do, 11% of cases could be resolved by that. And so that was really kind of uplifting. It's not a huge number, but it's impactful that, there was a case Dr. Hansen and I both had on residency in our R3s that Dr. Schellenberg, who's no longer working, had recognized it immediately on just case review. And that was really quite interesting that this, if someone just has recognition of the syndrome, the odyssey is terminated. They can kind of cold call it, which, harnessing that collective intelligence to me strikes me as something really ripe for kind of harvesting. And then on the other end, no diagnosis. So a majority of these cases with severe disease, severe phenotype, referred by some of the best US centers, and despite the entire clinical armament of a research apparatus that's as impressive as the NIH, a majority, 2/3, don't actually get diagnosed. So that's humbling, like we don't know everything and we can't know everything, and that definitely shows. What does this mean for us? So, change in diagnostic testing. It wasn't quite clear if that meant you would be testing more because you've identified a problem and now it needs serial testing, or you would truncate testing because you now have an answer. But the hope for us is that a diagnosis would stop unnecessary testing or shift the strategy. Change in therapy. This is probably the most meaningful one from a patient and physician standpoint or care team standpoint, that 21% of cases had something you can do about it. Many of them were actually vitamins, inexpensive B vitamins for neurological ailment. And then variant specific genetic testing, which is very helpful for the family and for, for the future generation. Interestingly, their financial insight was the cost of doing the UDP assessment was only 6% of the total medical cost of the patients that ran into them. And if memory serves, it was $300,000 US, and so 6% was. And so their remark is that being undiagnosed is expensive. So on the one hand, to de-diagnose is costly, and then to diagnose a person's, being undiagnosed and having no answer is very expensive. So you kind of have these competing needs. A focus on the UDPs for adults. This is a Belgian group that had restricted it just to adults. Again, there's variants of a theme. As you can anticipate, 18% yield is quite a bit lower than what they had at the UDP, but this is for adult cases. And they had a 12% therapeutic implication for their findings. And the advanced age and complex phenotypes probably reduced the diagnostic yield. There was roughly 329 patients accepted for their review. And this just, again, it goes over neurological as a predominating feature, and immunological was, again, much like the UDP's findings. So now a discussion about, St. Paul's and what we've had and where we're going. I mean, Casson Clinic has been, many people have probably rotated through that as the Chiefs Clinic. It's a decades-long institutional asset. I had rotated through there, and it was, inspiring to see these cases and how do we manage this uncertainty over not just a single visit, but months and years, and even longer sometimes. So it seemed like it was a naturally harmonized referral pathway, because many of these cases are PURCC. They meet all the defined criteria for a PURCC patient. And so this is the one-liner for what is the PURCC trying to achieve? It's a streamlined patient pathway for undiagnosed presentations, and they need to have something, again, equally concrete, biochemically, clinically, or radiographically. And, marked by multiple subspecialist opinions not being able to render a diagnosis. The slides will be available, but this is just our inclusion and exclusion criteria. Essentially, it's what we've been discussing, is that they need to have apparent and clinically significant damaging pathology. Here's a look at our workflow. So we want to get a cohesive vision for that patient's trajectory as they go through testing, particularly since there's no clear guidelines or directions for their problem, which is why they're here. So the triage nurse, who's an incredibly important member of the team and indispensable kind of navigator, reviews the patient, reaches out to any outpatient providers, gathers data, organizes that. They're reviewed in general consult with general medicine, that would be myself presently, and consultations rendered from that standpoint. An ad hoc panel, which we've been doing every last Friday of the month, is convened. So we do that either by Zoom or in person to review all the data. And really the secret sauce has been having radiology and pathology co-joining these events so that the clinicians at that time have direct access to clinical, pathological, radiographic correlation. So it's really, the secret is in the basic, is that everybody is there at that time. It's not an email chain. Everyone can speak at that time. So it's really in the relationship building and the discussion. We have the panel review, we iron out some recommendations, and then depending on the case trajectory, those cases are reviewed in a recursive fashion. And ultimately they'll have, one of a few outcomes is that there's a diagnosis achieved, there's no diagnosis achieved, or the diagnosis is unclear. But the idea is to give them some sort of sense of finality that, honestly, we've really looked at it. There's been a lot of brain power on the case, and we don't know if we can go any further. What are our goals? So, in the one sense, we want to have a value-based cost reduction. I mean, the purpose is not to go over value-based care, but really, people don't want to be aimlessly and frantically kind of going from appointment to test that really means nothing. And the qualitative metric is that, quality plus service plus access to care divided by the cost equals the value. So it kind of makes intuitive sense. We want to have a platform for collaboration and knowledge sharing, not just locally with our own colleague group, but eventually by expanding out with collaborations like with CORID and elsewhere. So, we want to counteract these issues of burnout in our cases. And when these come onto our plate and are added on, it can create a lot of tension that you feel like you're really alone. You're already dealing with a lot on your plate, and you want to have an environment or a growth aspect where you can grow into these cases and use these cases to grow into your clinical skills and be at the cutting edge. And we want to be able to eventually collaborate on a national and international level. For the patients themselves, I think we're moving on to more of our qualitative assessment with our so that data is ongoing. We're trying to generate that in an ongoing basis, but at least from the discussions at the foot of the bed, they just feel like it's great to have somebody that has their back. And that I think makes a big difference that, we could spend millions of dollars in care and then people go, I don't really feel cared for or wasn't really heard. So that's, I think, incredibly helpful. There's an educational mission that I think trainees need to have exposure to these complex cases early on, that it's not just, purple book medicine or the algorithm leads you there. And if the algorithm fails, then it's kind of just a shoulder shrug, that there is ways to work through these problems, and that we need to be comfortable in a increasingly complicated healthcare system that we need to manage diagnostic uncertainty and complexity. And eventually it would be great to collaborate with other UDNs and establish a network to discuss with them. So this is our workflow right now, last Friday of every month. And we started that just last November. So we've done 8 cases now, and 3 of them have been resolved, and many of them are still a work in progress. And I just wanted to share a review that one of our consultant radiologists, Dr. Tim Murray, has provided. And I mean, I'll just give you a few moments. I'm not going to read it out for you, but it really focuses on what are we going to do next for this really complicated patient. And it's about helping the patient rather than fiddling with the label. And Ronnie Ho, our resident pathology consultant, has found it's a lot of work to get those slides, and we're incredibly appreciative of their review, but being able to pull in different information, integrate, and actually have maybe another look at the pathology, because that's just a snapshot at that specific point in time, 5 years ago, outside of the forward moving context of how the case has evolved. So having a re-review of the pathology in the context of all the clinical information, I think, is much different than having the pathology at the time of for example, autoimmune hepatitis 5 years ago, or a hepatitis not otherwise specified versus, a hepatitis in the context of a variety of other neurological symptoms or cardiac symptoms or biochemical features. This is a look at kind of the throughput from Dr. Cassin's clinic and then how it relates to PURCC. So presently the PURCC is offered on Thursday afternoons as a half-day clinic, and then the Fellows Clinic is running on Tuesday afternoons. Since signing on to staff and expanding the outpatient portfolio, there's roughly 205 patients. This sort mechanism was a bit unclear on Cerner since 2022, 2023. And of that, it's supposed to say 25%, but yeah, so 25 out of those 205 actually secured a diagnosis that was clinically meaningful. Now, these aren't all home runs. Some of them were, your B12 was really quite low. Some of them, so it was just a matter of having a generalist review. Oftentimes they could be referred from a subspecialty provider or a GP in this instance. And so it just takes a second look sometimes. So not all of them were, rare disease game changers, but they were definitely impactful, and certainly they're big patient wins. It's great. They're happy to come at Christmas. They send you chocolates. So it's everyone is, really appreciative of the care. But I would say that many of them remain undiagnosed. So they're still waiting to be clarified, serial imaging, following findings that you don't want to jump on with an invasive approach because it'll cause harm to the patient as well. So it's just that watchful waiting pathway for these many of these NYDs, which I think they need that shelter as well, even though we don't have an answer for them. So, roughly 1 year in with the PURCC since 2022, Dr. Cassin's fellows and PURCC clinic, what's ideally the future goal, number one is going to be an integrated inpatient and outpatient diagnostics program. I think that the CTU in particular is a very excellent ecosystem for that. Many of the attendings here see, in a particular 4-week block with 5 very busy teams, there's always going to be 1 or 2 cases that are really puzzling. Everyone's had a try on it, and they need to have some sort of a next play that they can move from their inpatient to outpatient journey, particularly when they don't have a diagnosis. The idea behind that would be, although these cases that we've reviewed in PURCC, roughly 8 now, are incredibly interesting, they're being referred from the province's best experts in those areas. So they're probably going to represent more so those groups of patients in that cluster that would remain undiagnosed, organic pathology, but still undiagnosed, rather than someone who you could catch early on and essentially save, savings in patient and clinician anguish, as well as the healthcare system. I want to really focus on the trainees. I think that the cases can give them a lot of trepidation. Look how big the chart's going to be. I don't want to miss anything. But I don't think that's a healthy mindset to have on these cases at all. And then, so the only way to get less uncomfortable is to do it more. And then ongoing publication in the medical literature for really just knowledge of the experience, the story, and, disseminate how we and the patients kind of interact and how the diagnosis is eventually made. So we'll cycle back to our case number 1. So on posthumous whole exome sequencing, they're identified as having a ZMI-Z1 neurodevelopmental genetic mutation, which was pathogenic. And really looking at their symptom cluster, it was probably the entirety of their problems were explained by that. And so that was really helpful for closure for the family, because that had been something that they were incredibly committed to. And it was, a good legacy to be able to publish this in the medical literature as a case report. The case of kind of malignant ascites, ended up getting a diagnosis after a lot of outpatient work, and readmissions was a sclerosing mesenteritis variant that can present as a hilar mass and cholangiocarcinoma. And he's doing well on non-steroid disease modifiers. I still have to follow him every now and then. There's ups and downs, and obviously pivoting from hospice to then alive is a pretty big shift in your mindset and your long-term planning. So case number 2, we're working on it, but really eventually it took integration with Dr. Mattman and Dr. Dutz, and eventually getting the patient onto alpha-1 antitrypsin augmentation with a variant that has never been described in terms of alpha-1 antitrypsin, giving them that replacement therapy, and they've not had a recurrence of their skin disease. They've been on a study drug for their chylomicronemia, and we were trying to tie those two as there's some sort of translocation that could knock them out. And we never really could come to an understanding why they would have 2 rare things happening together. But it seems like the pancreatitis is controlled with Dr. Brunham, and the skin disease is controlled on alpha-1 antitrypsin, which is hard to access without either a clear lung or liver diagnosis. And the last one is waiting to be published in CMAJ. So look ahead, and this was ultimate diagnosis turned out to be toxocara causing eosinophilia, and the hypercalcemia seemed to be granulomatous in origin. And we have some PURCC collaborators that are on that publication. So probably in the next couple of weeks, we'll have it in press. So I think that's pretty much the presentation. Is the take home is, consultative medicine is a facet of internal medicine. I think every internist does consultative medicine, but much like perioperative or thrombosis, the healthcare system is so busy and so frenetic, and the pace is that you need to have a pathway for you to do this function, because it takes time, it takes effort, it's a different tenor of care that you have to do. So the CTUs have the patients, but they're also doing heart failure and COPD and delirium and meningitis. And then to throw in one of these cases in the mix, I don't know, it's very challenging. I mean, that's why I enjoy doing it. And not only can we, but we should, probably for the benefit of the patients and their experience. And we learn from those really tough cases. Like the rare disease informs us on how to practice our common diseases, or it gives us something to orient to. So if a patient has a fairly severe immunodeficiency, then you by definition are going to be learning about aspergillus or other disorders that they become susceptible for. And so I think it just complements your management of the common. And really, the technology is incredible, the scans, the genetic testing, the availability of genetic testing, but it's just in the basics. The complexity is all in the basics. It's about the relationships. It's about the understanding. It's about the communication. That's really the big thing, is that there needs to be time and funding to develop the relationships. These are my references, and I'm happy to field any questions.
We can start with asking people online any questions. We've got a lot of people online. I don't think I can see any questions.
Sorry, Nadia. Hi, this is Andrew Hurlbert.
Oh, hi, Andrew. Go ahead.
Hi. First off, thank you so much, Anthony. This is great. I guess my question is, how do you envision this kind of bridging the gap to that kind of access point from CTU and inpatient or inpatients, or even patients in critical care, in which there is a bit more of a time crunch?
I think having a line that you could call, that, I'm kind of at a stage with my current practice, like I was pretty inundated with a lot of clinical work, but making that time to give it a try, that, if you call through switchboard for a consultative medicine opinion or a PURCC opinion, then we will answer the call and try to get things through communication to have a higher throughput of cases that are more acute and therefore probably more likely to get a diagnosis. Sorry, Andrew, I didn't get your picture on there, but you've been through so many PURCCs. I'm sorry.
I didn't take it personally. It's okay.
But I hope that answers your question. That, yeah, I think at least at the same, I think starting locally, having a consultative medicine person that you can call, throughout the week to give a second review would be probably the sensible way to start. Yeah.
Anna?
Thank you. That's excellent. Is there any plans, or I don't know, that this might have to do with more privacy issues of the current clinics that have been running for several years now? In your case, integrating AI to help you to summarize or bring the information that you want to gather, to reduce the amount of time spent, and also just how do you see AI playing a role? I was at a patient quality and safety meeting in Singapore, and a whole afternoon was spent on kind of like use of AI and diagnostic uncertainty. And the case example was a mom who after 3 years of taking her child around, managed to get him diagnosed by putting things into ChatGPT. So do you see a role for that? Not to be disrespectful of any of the physicians who are involved. We will always have to be there, but do you see that coming? And is there barriers to that in terms of like information gathering, summarizing, and then eventually diagnostic reasoning?
Great question. I think there's 2 points to that. There is a privacy element, but certainly with anonymizing, I guess how can you anonymize someone so rare that there's only like one person of them in the province? So that could be the intrinsic problem with anonymization with hyper rare people. But from my own experience, like I do deploy AI to do the scribe work. There's also AI platforms that are just on information management, where you could just put in the referral package and it will look at all the data and organize it and that takes a lot of tweaking. I would say, just anecdotally, anonymizing the cases, even when the final diagnosis is present, it's a little, there's room. Then obviously the AI will grow, but we had a case of, well, we're not supposed to call it dyskeratosis congenita, but they had a telomere biology disorder that was picked up on a panel screen. And even with a bit of prompting, like you don't give it the full thing, it really couldn't quite make up that the alopecia, the fibrosis, the lung fibrosis, the pancytopenia, and it gets distracted. So if you give it some piece of information, it'll run with that, or so it still looks for those kind of pathognomonic features. So I think it's great, like if you can punch it in and it says, well, you have oxalate syndrome, whatever, inborn error. What was the cost? Like very little. So I think it's complementary, but I don't think it's going to be the all-seeing eye.
It was more around just because I would imagine that your chart review is probably like a package that's several inches.
It's painful.
And so is it helpful to have that? Yeah.
Yeah, I think they have a format called Clever Consult. It's specifically, so you don't actually need consent because it's just about information management. And so it will digest that package, and then, but that's still a work in progress. So the developer is a GI physician, and so it has that flavor in terms of the endoscopy reports and pathology, but they're very collaborative, and I think that would be helpful. It's the pre-charting that I think is the most devastating. I love seeing the patients, I love taking the history, but the pre-chart is the pain. Oh, Luke, yeah.
Oh, great. Yes, thank you. That was a great presentation, Anthony. I just want to make two comments. I think one regarding the AI issue. I think the strength of a program like PURCC is that we're trying to use every asset that's available to us. Like it's so different having the pathologist there in the room, right? Like almost every case of Castleman disease that I diagnose, the biopsy was already sitting in the lab. It's just that nobody told the pathologist that Castleman was on the differential diagnosis. And when we tell them, they're like, oh, well, if you told us that, we would have told you the diagnosis was Castleman disease, right? Like sometimes just that simple conversation between the clinician and the pathologist, clinician and radiologist is so helpful. And I think AI falls into that category. For anyone who's interested, the October 8th issue of New England Journal of Medicine has one of the most fascinating case records of the Massachusetts General Hospital ever published. Like I always tell residents, at least every couple months, you should pick up a physical copy of New England and look through the case records. Well, this one from October 8th, they pitted Gurpreet Dhaliwal, who's a well-known, he's kind of like the Anthony Gador of the United States. He's a well-known internist diagnostician. And they pitted him against Dr. Cabot, which is an AI algorithm. And it's a fascinating read. I recommend anyone who's, in the audience here, take a look at it. But I think AI is a tool and we should definitely use it. My second comment is that I think, I've loved the energy at PURCC. I think we have to keep in mind that no patient's goal is to have 100% certain diagnosis. Every patient's goal is to get on the right therapy. And sometimes when we go through these cases, it also, even if we don't arrive on an aha diagnosis, it gives us the confidence that, okay, this is the best working diagnosis we can come up with in the year 2025. And it's time to move on to treatment. It's time to try rituximab or try tocilizumab or try something that's sitting on the shelf.
Great. Thank you. Just want to ask if there's other questions.
I don't have a
Anna,
question,
yeah.
but I have a comment from someone who has briefly experienced the lack of diagnosis. I think the other part of this I'd be very interested in is the psychological effect of patients feeling that they're being heard. And I think that's probably a portion of this that might not quite be as evident to us sitting on the other side of the table, but I'd be very interested in terms of sometimes we don't need the diagnosis. We just want to know that someone who knows what they're doing heard our story and was able to tell us that the best physicians available to them is not able to give them an answer, and that's all it takes. And I think that part is also just as important as the diagnosis itself. So thank you for doing that.
No, I 100% agree. You can't always hit a home run. It's great if you can get somebody on a therapy, but I think the patient should always feel cared for. And presently, I would say, if you don't have, I can't help you is really often the thing, is that they just tumble. I can't help you, or, we don't know, or that kind of thing.
I think there's one question online.
Okay,
Is there a role for more standard use of whole genome sequencing at the onset to just have of covered given it's relatively inexpensive?
Yes, yes, I think 100%. The question was the role for whole genome or whole, I guess, panel exome sequencing in terms of, I guess, halting a diagnostic delay. I would say 100%. I'm a big, much like, you know, if you have a patient with fevers and you don't know, the next question, well, where's the CT scan? You know, if they haven't had the complete anatomical imaging. So I view it as that kind of a tool that it could reveal a lot of these cases and should be done earlier rather than later, almost as, well, we've tried everything else, time to check the genetics. I think that should be part of a complementary panel or very early on in the diagnostic cascade. There's challenges though, because there's a lot of variants of uncertain significance that could contribute to more questions than answers. But I think you can manage a lot of indeterminate testing with, again, the relationship. So you have the technology, you have the infrastructure and the relationship. If I had to err on one or the other, it's the relationship that needs the preservation so that you can guide them through. They've dealt with uncertainty the whole time. So, but you know, in a lot of cases, it does seal the deal and you have this test and you have a pathogenic variant. But I mean, sometimes the pathogenic variants don't make sense either. You're like, well, you definitely have this, but I don't know if it explains everything. Yeah.
yes.
Thomas?
The other interesting aspect of this that I think is not as appreciated, but probably something you recognize, is actually the experience of the clinician in a program like this. And I think when you talk about burnout and moral distress and the challenges we feel as providers, being involved in something like this gives you a sense of satisfaction and accomplishment that a lot of other areas of medicine don't give us anymore. And I think we all benefit actually from doing some element in our practice of vocational medicine, where the maybe the remuneration or the academic benefit you get from it is not that strong, but the sense of purpose is great. And I think sometimes we forget about that in the busy lives. We have to see, you know, a patient every 15 minutes all morning long. They all have the same diagnosis, the same problem. And I think we all benefit actually from being a part of something like this. So I guess that's my main comment, and I'm sure you feel that in seeing these patients and getting them answers. It actually is, I think, a very uplifting experience.
Thank you, Thomas. I'm happy to have you on the panel. And
I have very little to add as a cardiologist, actually. It's a weird field that I'm in that like there isn't as much diagnostic uncertainty, but I think seeking those opportunities out to be involved in rare disease management or in complex disease management is really valuable.
thank you. Yeah, I agree. Everything to see the patient, care for the patient, and then have the infrastructure to deal with. There's a lot of drudgery. Like, you know, the charts are huge. The time is extensive. The easy tests have been done. So it's really building out an infrastructure that can do that with alacrity. That it's let's go, let's get this done, and let's just take care of the patients.
I have a question. I think it sort of encapsulates probably the whole process, but you mentioned you had like 205 cases that got referred to, and they're all being referred by a lot of really smart physicians. Where are people going wrong? Like, why is it that the diagnosis isn't, I mean, the diagnosis, honestly, that you mentioned, I don't even know what half of them mean, but where is it that we're going wrong? Like, is it that it's a knowledge-based issue? Is it because a test sort of throws people in one direction? Actually, you need to pivot to another direction. Like, where is it that people are going wrong in their diagnostic process that leads people to not get these diagnoses for the ones that you were able to solve? And then another big question is, what do you think all of these undiagnosed people have? Do you think that they have something that is yet to be discovered? Or do you think that it's just actually a confusing picture of probably something that isn't really there? Or I'm just trying to wrap my head around those two very big questions.
Yeah, thanks. That's my heart rate's going up on that one. No, so early on in clerkship, it really stuck with me, the saying is, the smartest doc is the one last in line. You have the time, you have all the data, and sometimes things get, in just kind of left out there in the past, like, Dr. Chen mentioned, the pathology existed,
Yeah.
and so it just took a re-review with a different perspective, with a different filter, or, putting different rank orders of priorities on the problems. Another one is if you have the permission to think out. So I would say this on the trainees on CTU or in general, you're trained from early on about an approach that's choose wisely, be restrictive, don't order this. I mean, because again, we have to be wardens of the system. This is not the patient that you do that on, is when it's remained undiagnosed. You also have to identify if there's psychogenic disease. Dr. Gilks was here, but I think she had to go. You also need to understand that a lot of people have functional concurrence, that they do have some psychological or psychiatric or even Munchausen's, that they are presenting organic, but there's some other aspect to the story. So these are those kinds of clusters where it was just, I had the benefit of being the last in line. You take the time, and you're not particularly, like, if you're running a very busy cardiology clinic or a neurology clinic, you're not really going to be looking towards splenomegaly with the same perspective or agnostic interest as somebody that's a generalist specialist. So I think that would probably be it. And so I don't think it was that it was missed. It was just that things declare over time, is often what I would say. Yeah, and it can sometimes honestly, sometimes it's just completely unexpected. You just do, for this particular problem, I send this particular panel of tests. I'm not thinking about it in a deliberative sense, but I always check cortisol. And lo and behold, there it is. They have pan-hypo-pit, and you're off to the races. That was actually a really good early presentation in a fairly disabled elder, but who's now back to boxing again. And yeah, so that would be the one thing. In terms of like what's to become of us, or what are these, I think we're always dealing with, unknown, even from antiquity. They were dealing with sepsis and pancreatitis with no anatomical understanding. So we're just limited by the medicine of the times. So I think that there could be, I don't know, microplastics disease or some sort of other contaminant that we don't even know is causing these disorders. So, we rely on the science, and then we inherit the Nobel Prize wins so that we can give them to the patients. So that's, the big aspect of, technology just improves over time. So I don't think we'll ever get a complete understanding. The patient with the disease is way too complicated than the disease itself.
Great, wonderful. Thank you so much. Thank you, Dr. Chen, also for coming to our grand rounds. Thank you. Thanks, everyone.